Well, good evening, everybody. It's a great pleasure to speak about advanced ultrasound applications, including high-resolution micro-ultrasound for prostate cancer. And I'm a radiologist. I'm working in Paris, France. And the webinar will be about 30 to 35-minute presentation, followed with 15, 20 minutes of questions. Basically, I've been working with many companies and trying to improve image quality as well as for contrast imaging agents. This webinar is supported by Exact Imaging. So, as you know, the prostate cancer is a major healthcare issue, and it's the most common diagnosed malignancy in men. And to better get patient management, we need to have a very precise evaluation of prostate cancer, detecting all prostate foci, detecting high-grade lesions, staging, and doing follow-up. Basically, all diagnostic tests have a limited performance as digital rectal examination, PSA, or even conventional transrectal ultrasound. As you can see, the sensitivity of conventional transrectal ultrasound remains pretty low, and even lower in a recent study that we conducted in my department. Here on the on the right side of your screen, you can see that there's a slightly hypoechoic area that corresponds to prostate cancer, and you see the increased vascularity using a color Doppler. However, due to that very low sensitivity, it is recommended not to delay prostate biopsy in the case of abnormal digital rectal examination or increased PSA. Really, multiparametric MRI has changed the situation, the diagnostic capabilities of a radiologist and urologist. It's a combination of T2-weighted, diffusion-weighted, and dynamic contrast enhanced sequences has become a major tool for cancer detection and staging of significant prostate cancer. However, if you look carefully to the literature results, there's a high detection rate with a large variability, and you see in the sensitivity from 60 to 96% and a high negative predictive value. However, its specificity remains pretty low, except in a few studies, and as well as its accuracy is limited. As you can see from this graph, basically the low, small cancers and low-grade cancer are missed in the very large majority of MR studies. So the key point is how can we improve prostate cancer detection and patient management? As I did not mention that MRI is even missing a significant number of high-grade cancer, 4+3 or even higher than 8, decent 8. So basically we have on one side multiparametric imaging, MRI that combines the T2-weighted diffusion and perfusion imaging. And on the other side, we have multiparametric ultrasound, which is a combination of B-mode anatomy, vascular imaging, elastography, even perfusion imaging, combined with the 2D, even 3D and 4D imaging. And most people are not trying to combine the advantage of each modality, as these two modalities are not missing the same cancers. So really, the new vision, or the vision that I'm supporting for prostate cancer detection, is based on the combination of MRI and ultrasound. And basically, that's exactly what fusion imaging is doing for diagnosis or for biopsy and for biopsy. So let's see the conventional prostate transrectal ultrasound improvements that you can beneficiate. Improving conventional B-mode imaging has been the task of many ultrasound companies, and you can see a few of the names that we'll be using: tissue harmonic imaging and nonlinear imaging, compounding imaging, high-resolution imaging with the micro-high-resolution ultrasound imaging. But color Doppler also has been improved And I will try to show you how much these improvements are changing the vision that we have of the prostate cancer. Nonlinear imaging is mainly improving the contrast, resolution, and persistence. And you can see here in this example, conventional beam mode imaging. And now I'm going to the nonlinear imaging. Look at the difference. This is exactly the same patient. I'm doing it again, and you have a prostate cancer here on the posterior peripheral zone on the right side. So look the difference with the nonlinear imaging, and nonlinear imaging is very similar to harmonic imaging. Compounding imaging is another technique where each of the ultrasound beam can be stirred using phase shift, and this is also a technique that improves contrast, resolution, delineation of structures, including nodules, and reduce the clutter. So this is another example. This is harmonic imaging, and let's see what happens when we use compounding imaging. And you see how much contrast has been improved. Again, this is conventional beam mode imaging, and now we're moving to compounding beam mode imaging. And you see here a small Gleason 6 lesion on the left posterior peripheral zone. New techniques can include the use of simultaneous biplane imaging, as you can see in this loop. And you see how much we can take advantage of the localization of each abnormality using the simultaneous biplane imaging. This is good for biopsy, and here you have the line for the biopsy. Carving imaging is another approach, a filtering approach, and you see now going from conventional imaging, and you'll see the change when we go to that filtering. This is now on. And you see the reduction of the speckle and contrast resolution improvements. And that's exactly what we want. We want to get better contrast and better resolution. Better spatial resolution can be achieved using a higher frequency, and this is done in microconvex transducers as well as in biplane transducers. And now with the micro-ultrasound that can go up to 29 megahertz, with the spatial resolution reduced to 70 micrometers. And this is the kind of very subtle, very tiny difference that we can see with the increase in resolution with this transducer. And there's an anterior Gleason 8 prostate cancer. And you see how well we can detect it with this approach of a higher frequency imaging. Of course, now moving from 8 to 29 megahertz makes a big difference, and you see on this loop, and this is with the linear transducer, you see the very good delineation of all and identification of all anatomical structures inside the prostate, including urethra, including ejaculatory ducts, and the peripheral zone that is here close to the rectum wall. Of course, with this technique, we're detecting so much lesions that a score has been developed to avoid biopsying some of the very small or the very benign pattern lesions. So using that score, it is possible to improve the characterization of the nodules. And in this case, you see transrectal, transperineal biopsy using conventional systems here, and transperineal biopsy using the exact view imaging at very high resolution, very incredibly high spatial and contrast resolution. So basically, with the high frequency imaging, we can see, or micro ultrasound, you can see features that we couldn't see before, and basically a detection rate of prostate cancer up to 10% more than using micro ultrasound imaging. And this is really coming from all over the studies that have been published, despite the fact that this is quite recent technique. you see improvement in accuracy as well as in guiding prostate biopsy. And this works surprisingly even in the anterior lesion. You see the cancer, clinically significant prostate cancer detection rate that are really, really high in terms of sensitivity, but of course, specificity is going down. So this technique is very exciting and probably part of the future. Improving color Doppler is very, very interesting, as we know that the aggressiveness of prostate cancer is really related to the development of neovascularization. So Doppler is playing a key role. We're using slow flow settings with a high gain and low wall filter. And of course, as it is critical not to press on the prostate with the transducer. Otherwise, all flow would be removed. We can use directional color power Doppler imaging, and this is the kind of image that we can get, or even Micro-Doppler multipulse technique that has been developed. Of these technique, probably one of the most exciting one is the superb microflow imaging, and you can see how well we can analyze and detect the microvascularity inside this prostate cancer. We can combine this with contrast agents with ultrasound and accumulate the signal of the bubbles traveling in the imaging plane, and this is exactly what you're seeing here. So we have here the true pattern distribution of the vessel inside the prostate or even inside the prostate lesions. We can even combine this with fusion imaging, and you can see here the result on this example. So these techniques are very exciting and just leading to the major improvement in prostate cancer identification. Now going to new modalities, we have clearly two kind of approaches. One is elastography, and the second one is contrast enhanced ultrasound. We will start with the contrast modes. Why? Because we know that prostate cancer is a very stiff lesion with increased vascularity, and we know also that there is correlation between the Gleason score and aggressiveness. But unfortunately, as you will see, not all cancers are very stiff or hypervascular, and all stiff lesions are not prostate cancer. So what can we do with contrast enhanced ultrasound? You know that we can inject these microbubbles and increase the signals inside the prostate depending on the amount of vascularity. So this approach is good and increase the detection of perfusion, blood flow, slow blood flow vessels, and analyze and detect tortuous velocities, tortuous vessels, shunts, and even abnormal resistance. But ultrasound contrast agents are also mandatory if we want to quantify the amount of blood flow inside the prostate or inside lesions. And this is something that has been done. It's probably a very exciting approach. Prostate cancer detection can be improved or characterized using that approach. We can also grade the prostate cancer, guide the biopsy, and follow the patient. So these microbubbles are oscillating inside the blood pool, and this is how they increase the backscatter signals to the transducer, and they can even produce frequencies that are not in the transmit pulse. However, prostate contrast enhanced ultrasound is a technical challenge because the frequency that is used for prostate imaging with the ultrasound is quite far. The frequency is much higher than the resonant frequency of the bubbles. There are issues dealing with the transducer focalization and of course from the subjective assessment of the enhancement. There are also issues due to the prostate gland anatomy, as this is not a very highly perfused gland compared to the kidney or to the liver, And there's also a major change due to the BPH development with increased size and vascularity. And of course, the prostate cancer vascularity, increased vascularity compared to BPH is difficult to identify. The last issue, or the last issues, are the typical pattern of enhancement of the prostate cancer will not last much long, only 7 to 10 seconds. And you can see a major difference comparing the prostate cancer here and the prostate nodule of prostatitis. So we know that most of prostate cancer will be with increased perfusion, except the low-grade cancer, indifferentiated adenocarcinoma and neuroendocrine prostate cancers. So the big issue for us is the very limited transient enhancement of the prostate cancer compared to the surrounding prostate, and this is the surrounding adjacent prostate. So how much is prostate cancer perfusion increased? And here you can see from a study that we sent for publication that if we look at the peak enhancement of the non-cancer compared to the cancer nodules, you see that there's a major increase. Look at the p-value in between the between the cancer and the non-cancer. And this is true for all perfusion parameters that we can extract, including the washing area under the curve, the washing rate, the washing perfusion index. Look at the p-value. So clearly, the contrast enhanced ultrasound can have a key value for diagnosis of prostate cancer. But as I told you, this enhancement is very transient. So in our routine practice, we should find the most suspicious area and get a stable view, and then we can inject contrast. And this most suspicious area can be identified using a B mode, color Doppler, power Doppler, Micro-Doppler, or even Shear wave elastography. And this is exactly what we're doing. As you can see in this patient, the pacemaker that made the MR examination impossible. So this is a totally normal B mode imaging. And as soon as we started at the base, you see that there's a very steep abnormal area, and look at the corresponding B mode. There's absolutely no abnormality. So finding the right plane, then we could inject the contrast, and you will see that the contrast enhancement is very strong, very abnormal, and the biopsy at the site of this lesion revealed that there is an 8 lesion with all biopsy positive, and none of the systematic and other biopsies performed in the prostate showed any cancer cells. So this is the major limitation, and there is a possibility, a quite elegant way to solve the technique. This issue is to use 4D contrast ultrasound, because we will be able to obtain volumes with a contrast enhanced during the contrast administration. And this is a patient where we suspected a lesion on the left side, and I was watching at the left side, but look at here, there's something that is enhancing on the right side. And during a few volumes, and this is a few seconds, you see that the contrast is really strongly different in that nodule compared to the overall prostate. And this lasts about 4 to 5 volumes, meaning probably 5 to 10 seconds. And after that, the entire prostate starts to enhance, while the contrast enhancement in the nodule is becoming reduced. And now everything is washed out, and this is probably 8 to 10 seconds after the start of the enhancement of the lesion. There are many studies published in the literature about contrast-enhanced transrectal ultrasound for prostate, and this has been reported a few years ago at USNA, and you see that basically it's adding 10 to 15% of significant prostate cancer to the systematic biopsy, or using targeted biopsy to the most abnormal areas or highly vascular areas. There's a meta-analysis showing that the pooled sensitivity was 70%, and specificity was remaining quite high around 74%. That's interesting because remember that the conventional B-mode imaging sensitivity was in between 30 to 50% and probably closer to 30%. So contrast-enhanced ultrasound is a promising tool for prostate cancer detection that cannot replace systematic biopsy, and we strongly need the 3D approach or 4D approach to detect the lesions. It is useful to monitor focal therapy with a HIFU or cryoablation, and there are a few papers now coming to demonstrate the value of this application. The next topic is prostate elastography. We know that prostate cancer is stiffer than the normal prostate tissue due to increasing cellular density, microvascularization, and destruction of the glandular architecture. So why should we measure prostate tissue stiffness? Because clearly we have demonstration in vitro, a demonstration that prostate cancer tissue is stiffer than a normal BPH or normal prostate tissue. We have clearly two different approaches. One is the quasi-static elastography, where we alternate push and relax push on the prostate. And this is done with a transducer. Then we just exert some pressure on the rectal wall, deforming the prostate and releasing that pressure. Or we can even try to use internal deformation like cardiac beats or breathing for thyroid. And this is a thyroid example. There's a totally different approach where there's no need to deform the organ using the transducer, and that's shear wave elastography. Shear wave elastography, mainly RF techniques, can identify stiffer areas in real time, and this is mainly real-time shear wave elastography. And I showed you a couple of examples of this technique. So going to transrectal strain elastography, we just push and release the push in the prostate through the rectal wall, and basically there will be a color-coded map of the tissue deformation called strain elastogram, and the stiffer tissue will appear with the blue colors and will be soft, and while the soft tissue will be coded in red due to higher strain. There are some quality index that that can help to ensure appropriate frequency push and release, and quantify the applied pressure or help to apply the right pressure with a transducer. This is not a quantitative elasticity technique. We can provide semi-quantitative measurements, and the color scale is distributed between the highest and the lowest strain in the region of interest, which makes a big difference depending on the position of the region of interest. And it is mandatory to avoid any slippage, any movement during the compression, which is quite difficult. And this happened up to 32% of the case. But however, you see that this nodule is clearly very, very stiff, and it will appear with the blue colors. The strain elastography requires quite a significant learning curve due to limited reproducibility, wide variability, slippage artifact. So these are recommendations coming from the ultrasound med biology paper from Richard Barr, showing that it is really necessary to get the most appropriate training. Transrectal shear wave elastography is totally different. So because it is not necessary to compress the prostate, making it less operator dependent. So there will be generation of an acoustic radiation force pulse, and then the generation of an ultrasonic wave to capture the shear wave propagation. And we know that the shear wave speed is linked to the tissue stiffness properties. The shear wave speed will increase with the stiffness inside the prostate or inside the nodules. So this is a much dynamic quantitative map of the soft tissue viscoelastic properties, and it's quasi real-time imaging technique. I mean, this is 1 to 2 images per second. And the stiff areas, at the contrary of the strain elastography, will appear in red colors, and the soft tissue will remain blue colors. And it is possible to quantify with the region of interest very precisely the tissue elasticity values, and even make some comparison, some ratio between two regions of interest, one placed in the most suspicious area and the other one in the adjacent normal prostate. So clearly, step one, create a radiation force. Step two, image the propagation of the Shear wave. And step three, get the appropriate quantification process with a color map reflecting the stiffness of the tissue. And what is very interesting is that this technique is exhibit a very good reproducibility wherever you are in the prostate, at the base, at the midgland, or at the apex. In practice, you see maybe a suspicious area, but as soon as you start with the technique, you see a very abnormal extending stiff area with the red colors, and then you can all characterize abnormal, a tiny abnormal area with a B mode, detected with B mode, or you can also detect a lesion scanning from the base to the apex, scanning very slowly and waiting for stabilization of the signals. When you store the image, it is always possible to calculate again the stiffness values and ratio on steel frames. So this technique is very exciting because the overall peripheral zone is very, very soft. So it's very homogeneous and soft. It's color-coded in blue colors, in deep blue colors, and with a very homogeneous pattern. And in this case, we're moving from the base to the apex, and you will see that the peripheral zone, and this is the entire peripheral zone, will be color-coded with these deep blue colors very homogeneously. The transition zone, unfortunately, is very heterogeneous, with the stiff areas corresponding to the nodules, adenomatous nodules. In the case of calcification, always look at the B mode image when you see a stiff area, and then you'll see that these are just calcifications. The appearance of prostate cancer is a very stiff, heterogeneous, hypoechogenic area with a very stable signals, and in this case, you see stiffness values up to 120 kilopascal, while the peripheral zone was below 23 kilopascal. So very stiff area, even in the anterior zone. And in some cases, the color and the B mode ultrasound image is normal, the MRI is normal, and you see that this is a very abnormal area just detected by Shear wave elastography, and the biopsy revealed Gleason 7, 8 millimeter tumor, while all remaining biopsies, systematic biopsies, were just showing inflammation or normal prostate tissue. Clearly, if you compare the performance of a prostate elastography to random biopsy or even to radical prostatectomy, you'll see that this technique is strongly improving the detection of prostate cancer. And you see that for Shear wave here, in this case, the accuracy is above 70%, and sensitivity could be as high as 92%, except in a single study, with a specificity that remains pretty high. So this is very exciting, and this has become really part of our routine examination. And what is also interesting is that stiffness is correlated to the Gleason score, and stiffness is increasing with the Gleason score. And with a 35 kilopascal as a cutoff value, and to maximize the Youngden index and elasticity ratio between the nodule and the surrounding prostate of 1.5, we could obtain very, very high sensitivity, as you can see, per patient 92%, and negative predictive value of 94%, while the specificity was remaining pretty high. And you see again the very strong difference between benign and malignant nodules in terms of elastography. We can also improve biopsy guidance directly on the stiffer areas, and you see that in this study we found that systematic biopsy cancer detection rate was only 12%, while targeted biopsy on the stiffer areas was almost 40%. So shear wave elastography is not magic, of course. It has some limitation, including pressure artifacts, and this is particularly true when the prostate is getting bigger, it's pushing on the rectal wall, the slow frame rate, limited size of the region of interest for large prostate, and signal attenuation in very large prostate or anterior gland. However, it provides very good and very interesting results compared to conventional BMOD imaging of the prostate. And as I told you, not all prostate cancers are stiff, and all stiff lesions are not cancers, and this is particularly paying attention to the calcification. As you can see in this other example, you see the stiff area, but just look at the BMOD, and this is a very obvious calcification. So how do we manage multiparametric ultrasound? Basically, in routine practice, we use the optimized BMOD imaging using the best transducers that we have. We use conventional color flow imaging, conventional micro-Doppler, and shear wave elastography. And if we don't see any suspicion area, we just stop. And of course, we, in the interest of the patient, we always perform MRI before biopsy, prostate biopsy. If we see an abnormal area, then we use contrast-enhanced ultrasound and contrast-enhanced micro-Doppler, and this is just before the fusion biopsy to improve targeting of the needle inside the prostate. So now we have new fusion procedures that allow fast and accurate fusion biopsy. And this is done with electromagnetic sensor and a 2D probe. We just create a 3D volume with a 2D probe. Then, and this is exactly what you saw, we created the volume. And at the end of the volume creation, we can confirm the fusion. We do some volume check just to be sure that we're exactly at the same place. And we can combine this with the tissue imaging or even with the diffusion imaging. So it's a double fusion technique. And at the end, we use the automatic synchronization, and with automatic synchronization, the fusion is done. And it takes less than 45 seconds to go from non-fusion to totally fused volumes. And this is probably the way to go. The fusion imaging can be combined with all the techniques that I mentioned, BMOD imaging, transrectal BMOD imaging, but also shear wave elastography, as you could see in this example, or contrast-enhanced ultrasound. And this is the combination of the diffusion tissue with a conventional imaging. And you see here, fusion of MR with contrast-enhanced ultrasound. So that's probably the best way to go for getting the best evaluation of prostate cancer, best extension of the prostate cancer. So my take-home message will be, you'll see, or you have seen that conventional prostate transrectal ultrasound has a very limited performance. There are some significant improvement now on BMOD imaging and color Doppler imaging using many tricks developed by manufacturers. Multiparametric ultrasound has become real, and the improvement can be also achieved through the use of much higher frequency, like micro, high frequency, high resolution ultrasound. The next tools could be elastography and contrast-enhanced ultrasound. And this can be applied for characterization of area or nodule detected at MRI, ultrasound, color Doppler, or contrast enhanced ultrasound, detection of suspicious area, targeting biopsy for detection and staging of prostate cancer, and fusion with all modalities to MR. Probably, maybe the future will be a new diagnostic approach, could be the fusion of the multiparametric MRI and multiparametric ultrasound volumes, not anymore slices, but volumes. But the key point remains training again for the detection of the suspicious areas and to be able to perform directly ultrasound-guided biopsy. Why? Because despite the advantage of fusion techniques, the better way to be very accurate in your biopsy will be to identify on B mode the abnormal area, see it real time, and just stick the needle inside the abnormal area or the nodule. And this would be much better, much faster, and much more accurate than any kind of fusion approach. So thank you very much for your attention. I hope you are getting very excited with all these new features, and I'd be happy to take your questions. So I see that there's one question here coming. What is the incidence of malignancy in parietal 3 lesions? This is a very good question. Basically, it's really depending on the study published in the literature and has no direct link with this presentation. So for the Pirates 4, we know that malignancy is found in probably 70 to 80% of the cases. For Pirate 5, it's around 85 to 95% of the cancers, and the Pirate 3 is in between 20 to 40% of cancers. Okay, so the next question is, what is the performance of multiparametric ultrasound for anterior tumors? So this is a very good question, actually, because we know that prostate cancers are missed by MRI, mainly when they are posterior against the rectal wall, and that multiparametric or ultrasound, just ultrasound, is missing anterior tumors. So, and anterior tumors, as I showed you, the case, are very difficult to identify by B mode or by shear wave elastography due to the attenuation. So I cannot give you numbers because there's no good literature on the identification of anterior tumors with ultrasound. But I think it will be not so bad, and I'm expecting numbers in between 50 and 70%. Next question is, what is the current status of transrectal ultrasound elastography? So the current status of transrectal ultrasound elastography is basically just linked to the technology, and it depends to what kind of technique you use, strain elastography or shear wave elastography. Strain elastography is available for almost, I would say, all ultrasound manufacturers dealing with the prostate and on prostate transducer, transrectal transducers, while shear wave elastography is available only on a few ultrasound manufacturers. So, of course, and the literature is much more recent. So, I would say it requires more publication, more training, or I would say more experience, more studies than for strain elastography. The literature for strain elastography is quite rich now.